The two videos, Radiographic Interpretation, the Differential Diagnosis, a review for dental students and practitioners, include a total of 17 lectures. The complete video series, including all 17 lectures, will both serve the dental curriculum and be helpful for review prior to national board examination and for practitioners. Each lecture will be illustrated using cases that may be included in your differential diagnosis. Each example will include a clinical description of a patient who presented for dental care. This free video, Those Lesions Not Associated with Teeth that Present as Multilocular Radiolucencies, is Lecture 7 of the series. You may view this free lecture for your own assessment as to quality and content. Radiolucent lesions that are not associated with teeth may present as unilocular, having a single pathologic compartment, multilocular, containing two or more pathologic chambers partially separated by septa of bone, or generalized radiolucencies. Each category in this lecture will be illustrated using a selection that may be included in your differential diagnosis. Other choices for each category, generally in descending order of frequency of occurrence, may be found in the handout. Each example will be preceded by the clinical description of a patient who presented for dental care. Pathosis that presents with a multilocular radiolucent appearance may be found in the maxilla, but is more common to the mandible. The true multilocular radiolucency contains two or more pathologic chambers partially separated by septa of bone. These septa may be relatively wide and radiographically distinct, or thin and indistinct, causing the lesion to appear more unilocular. The terms soap bubble, honeycomb, and tennis racket have been used to describe the various pictures of multilocular radiolucencies. Soap bubble is used for those lesions consisting of several circular, variously sized and overlapping compartments. Honeycomb is applied to those whose compartments are small and relatively uniform in size. Tennis racket is a description of those compartments that are angular rather than round. These angular compartments have been formed by relatively straight septa. The multilocular lesion pictured here may be described as being soap bubble-like in appearance. It is important to remember that the multilocular appearance is not unique to any radiolucent lesion. In one patient, a lesion described as having a multilocular appearance may present in another as having a unilocular appearance. Factors such as anatomic location and maturity of the lesion may have an effect on its appearance. A 25-year-old Hispanic female presented for dental care. Her chief complaint was a swelling of the left side of her face. This swelling appeared to increase in size over the last year. She reported no pain, had no paresthesia of the left side, and no ulcer or fistula formation. Intraorally, there was an obvious and bony hard swelling of the mandibular left posterior. Regional teeth tested vital. A panoramic radiograph revealed a multilocular radiolucency in the mandibular left molar ramus region. The periphery of the radiolucency appeared well defined. The border was smooth and curved. The internal structure was mostly radiolucent with fine to coarse bony septa that gave the lesion a soap bubble-like appearance. There appeared to be no tooth displacement, but some resorption of the apices of the first and second molars. These historical, clinical, and radiographic findings are consistent with ameloblastoma. The ameloblastoma is an aggressive odontogenic epithelial tumor. It represents about 10% of odontogenic tumors. Ameloblastomas have been found to be slightly more common in males and more common in African Americans. Ameloblastomas have been found in the young and the elderly, but the incidence peaks between the ages of 20 and 50, with an average age at discovery of 40 years. It occurs 5 times more frequently in the mandible than the maxilla, and most commonly in the posterior of both jaws. It is painless and slow-growing. It may cause migration and loosening of teeth with root resorption. The ameloblastoma may expand and thin the cortical plates. Frequently, it erodes the cortical plates to invade soft tissue. Radiographically, it may present as a well-defined and frequently multilocular radiolucency that is either soap bubble-like or honeycomb in appearance, or a corticated unilocular cyst-like radiolucency. Lesions in the mandible tend to have a multilocular appearance, while those in the maxilla are more commonly unicystic with more ill-defined borders. This occlusal radiograph of another patient illustrates the honeycomb appearance that may be taken on by ameloblastomas. You can also see that the expanding lesion has thinned the facial and lingual cortical plates of the mandible. A 16-year-old African-American male presented for dental care. His chief complaint was a non-tender swelling of the anterior of the mandible. He reported that this swelling had been evident for at least 3 years and that a dentist had attempted to drain the area on 2 separate occasions. Palpation of the area elicited crepitus, and aspiration returned bloody fluid with no debris. A panoramic radiograph revealed a well-defined unicystic radiolucency extending from the molar area on the right to the molar area on the left. The inferior border of the mandible was expanded and thinned. The lesion appeared to have displaced some teeth and caused root resorption. The usual radiographic appearance of the lamina dura and periodontal ligament space of some teeth in the area appeared to be lost. All regional teeth tested vital. A biopsy returned the finding of ameloblastoma. Ameloblastomas may be of the solid or cystic type. The cystic type may develop as a single entity or may arise from the epithelial lining of a dentigerous cyst. The presence of a cystic variant may allow for the return of fluid on aspiration and may prompt the incorrect impression of a cyst. Unfortunately, it is not possible to distinguish between solid and cystic types on radiographic examination. Treatment for the ameloblastoma is surgical resection. In spite of this, recurrence may be as high as 30% in the mandible and 50% in the maxilla. The differential diagnosis of multilocular radiolucencies should include ameloblastoma, central giant cell granuloma, odontogenic keratocyst, odontogenic myxoma, and ossifying fibroma. By consideration of the patient's age, sex, and race, the location of the lesion, association with tooth displacement and/or root resorption, and the radiographic appearance of the internal structure of the lesion, the clinician may rearrange this list to an order of frequency. The unicystic variant, also known as the mural ameloblastoma, may arise from the epithelial lining of a dentigerous cyst and is radiographically indistinguishable from the dentigerous cyst. You should keep in mind that malignant variants of the ameloblastoma do exist. A 25-year-old Caucasian male with an extensive dental history presented for dental care. His chief complaint was a painless swelling located in the mandibular anterior. He was unable to say how long this swelling had been present. He reported no history of trauma. On clinical examination, the area was found to be tender, and the overlying mucosa appeared slightly purple in color. A panoramic radiograph made during the course of the examination revealed a well-defined multilocular radiolucency located in the mandibular anterior. A biopsy returned the finding of central giant cell granuloma. The central giant cell granuloma is a non-neoplastic reactive lesion. It is a relatively common lesion affecting adolescents and young adults. At least 60% of these lesions occur in patients under the age of 20. The central giant cell granuloma is slowly growing and painless. These characteristics may account for the older age of this patient. The central giant cell granuloma occurs twice as often in the mandible as in the maxilla and usually anterior to the first molar. Lesions in the mandible may, as in this example, cross the midline. Radiographically, the central giant cell granuloma usually presents with a non-corticated but well-defined border in the mandible. In the maxilla, the border may be ill-defined. Its shape may vary from unilocular to multilocular, and its internal structure may vary from completely radiolucent to a granular pattern or to a pattern with ill-defined septa. The multilocular lesion illustrated here may be described as having a soap bubble-like appearance. The central giant cell granuloma will often displace teeth and cause root resorption. An uneven expansion of the jaws is commonly found. The radiographic and histologic appearance of the central giant cell granuloma is identical to that of the brown tumor of hyperparathyroidism. Because of this, if a central giant cell granuloma is found in a patient in the third decade of life or later, hyperparathyroidism should be considered. A 9-year-old male presented with a bilateral expansion of the mandible. A panoramic radiograph made during the course of the examination revealed a well-defined multilocular radiolucent process that involved the entire mandible. This condition was ultimately diagnosed as cherubism. Cherubism is a rare genetic disorder affecting the jaws almost exclusively. It is inherited as an autosomal dominant trait with variable expressivity. It more commonly affects the mandible, but may also affect the maxilla or in some cases both jaws. Bilateral mandibular expansion usually appears between the ages of 2 to 4 years. There is an increase in jaw size until about 7 years of age, after which the process appears to plateau until puberty. At that time, there is often a slow regression in the facial appearance. Radiographically, cherubism is characterized by a well-defined multilocular radiolucency that produces a soap bubble-like appearance. Usually the process begins in the molar area of the mandible, grows posteriorly to the angle and ramus, and may grow anteriorly, as in this example, to the midline. The mandibular cortex is thinned out and may be absent in areas. There is usually a premature exfoliation of primary teeth and many missing, malformed, and unerupted permanent teeth. The radiographic appearance of cherubism may be similar to that of the giant cell granuloma. However, cherubism's bilateral presentation should provide a clear differentiation. Because of its rather unique presentation, the diagnosis of this condition may be based on the age of the patient, familial, and radiographic evidence. To watch the complete video, go to MediaMedent.com, scroll down to Free Lectures, and select the corresponding video.